around women health, awareness about around all the artificial things that we engage in, and vanity has its own impact on our health. And I think it's time to turn the tables on the other side.
The problem is really at two levels. One is, like I said, with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
Why do you think that the people in US, they are diagnosed stage 0? 80% of the ladies, the disease is diagnosed in stage 0, 1 and 2. While in India, it is 80% stage 3 and 4. Why? Only one reason, the awareness.
You know, the single biggest risk factor for all cancers, including breast cancer, is aging. If you live longer, then you are more predisposed to get all kinds of non-communicable diseases, including cancers, including breast cancer.
What I feel is what is lacking in our country is, which is lacking with most of our public, is they feel that they will only go to a doctor or they will only go to a healthcare provider when there is a problem.
And I think there is a lot of work which needs to be done at the community level if we really want to make this country breast cancer free.
So there were three things which I think you should not have a fear, you should have an early consultation, and you should not consider any other pathy. You should go for only evidence-based medicine.
NCCN guideline says if you are at high risk for male breast cancer, which is you had a testicular cancer, you survived, there was a radiation history, you have a cirrhosis of the liver, family history of breast cancer, prostate cancer, then you should do a breast self-examination.
Like anybody else, I never thought that, as a male, I should think about breast cancer, right? And it is something that unless you hear somebody or you understand the science, then you see that yes, you are equally at risk. Maybe your risk proportion is low, but it is not that you are out of risk.
Cancer is seen in females, and that is one of the things. Second thing is male breast cancer. Either their daughters or wives, they will come and represent them. And that is another reason why patients don't come forward for getting proper diagnosis.
डरो नहीं, अगर डरोगे नहीं तो कामयाब रहोगे। अब हम उसको लेके घूमेंगे तो बीमारी हमारी बढ़ेगी, घटेगी नहीं।
जो भी लोग आपको देख रहे हैं उनको अब शायद कैंसर के बारे में सुन के डर नहीं लगेगा और लगेगा कि ये ऐसी बीमारी है जो सब जीत सकते हैं, जो सब लड़ सकते हैं। हमारे साथ जुड़ने के लिए बहुत बहुत शुक्रिया। To fight against breast cancer, we need awareness and action at all levels. And to make every woman and man become the ambassador of good breast health, we at the ISW Council have begun a mass movement of taking a pledge that each one of us will talk about breast health with 5 people in our life, women or men. This is a pledge that can really save the lives of so many women who get impacted with breast cancer. Lawmakers, social leaders, influencers, and medical experts who are joining us to chart out a way forward to prevent breast cancer in India have also shown their exceptional support to this campaign. We are thankful to Novartis India for its support to this movement. We will request all our panelists and viewers today to sign this pledge by clicking on the link comment box in this live post. You'll find a link there, you can click on it. Or if that doesn't work for you, you can also sign the pledge by visiting our website, www.iswcouncil.org, and you will find a section where you can sign this pledge. After you sign your pledge and you go and click on the link, you will receive a certificate of pledge with your name. Do share this certificate on your social media handles and tag 5 people to take this pledge as well to promote breast health of our women and to reduce the incidence of breast cancer in our country. So we urge everybody to support us in this campaign to strengthen this movement and make India breast cancer free. Now, breast cancer is also amongst the most, it is of course one of the most prevalent cancers amongst women in India. But remember, it is a screenable cancer. This is why it is important to do self-breast exam every month to check if there is something unusual in your breast. And if there is something, then consult your doctor on the next steps of the journey. Now, you may have to undergo a compression mammography, which has been known as the gold standard in breast cancer detection. In our show today, we will discuss evolution of breast cancer diagnostics. And to discuss this, we have an eminent panel joining us now. Please welcome Professor Ravi Mehrotra, Chief Executive Officer, India Cancer Research Consortium, ICMR-DHR. We also have with us Dr. K. Kalai Chelvi. She's Senior Consultant Medical Oncologist, Apollo Specialty Cancer Hospital, Chennai. We have Dr. Manjari Bakre. She's founder and CEO of OncoStem Diagnostics. We also have with us Ms. Nareen Yasar. She's Value and Access Director, Novartis Oncology, the Amakor region. And we also have with us breast cancer survivor, Aisha Nikhat, who's joining us now. And we also have with us Dr. Samir Kaul, Senior Consultant, Surgical Oncology and Robotic, Apollo Hospital, Delhi, and founder and president of Breast Cancer Patients Benefit Foundation. A warm welcome to all of our panelists for joining us today.
Thank you so much.
Right. So let me begin by asking Dr. Kaul, what are the affordable diagnostic options that we have that can prevent, late-stage cancer or can help in an early detection of cancer? We are trying to create awareness about breast self-exam because it's completely, there's no cost involved and it really helps in early detection, but the awareness level is very low. So are there affordable diagnostic options which are also available to detect cancer early?
I think the first thing that one needs to have before we talk about, thank you for having me here. Good evening to everybody on the panel. The first thing that we need to have is the index of suspicion in a human's mind. Now that is a function of, according to me, the awareness levels in the community, in the society at large. The simple fact, I will enumerate to you lots of high technology products after this, but it never fails me to cite the importance of the basic comfort that any lady, any woman, or a male has with his or her breasts. To be comfortable with your own body, the back of your mind, so that you can objectively evaluate it every now and then and be conscious of your own body is perhaps the single most important prerequisite for this whole process. And then, of course, a simple ultrasound of the breast, a simple mammogram machine, a habit of palpating your left breast with your right hand, or your left breast with right breast with your left hand in the private concern of your bedroom or your toilet or wherever you're comfortable. Very, very, very simple things. But consistently, as a part of your lifestyle, are the three most important things which perhaps are available at more places than one would feel, one would like to know, even in the depths of my own country, India, which has got a very heterogeneous distribution of infrastructure as far as this is concerned. But these basic things would at least be available at the district level, if not the sub-district level country. And that, I'm sure, is changing, because with the new health system in place and the Ayushman Bharat and the wellness centers having come in, and as they are implemented across, I'm sure the penetration will be even at the sub-district levels of my country, ideally, at least on paper, and I'm sure in practicality as time goes on also. But these are just diagnostics, basic diagnostics that filter out and that create a further population which needs more diagnostics. And one of the basic more diagnostic armamentarium that I would need to confirm whether a lump anywhere in the breast or an irregularity anywhere in the breast is a cancer is a simple fine needle aspiration cytology. Now that again, in my own country and in similar countries across my borders, would be available at least at the district hospital level. So a pathologist or a cytopathologist or a pathologist who's trained in cytopathology reasonably to be able to give me a diagnosis for a few cells which have been aspirated by a simple syringe and a 26 gauge needle onto a glass slide and give me a diagnosis should at least be available at the district level. Now, these are the basic diagnoses. But once the diagnosis is made, and we are talking about special stuff, and that special stuff pertains to 2 points. One is, I need more imaging definition on what that lump or that cancer is all about. When I say more imaging, then I'm talking about higher imaging modalities like an MRI, for instance, of the breast, with its attendant positives and negatives. I'm not going to go into those debates, but an MRI of the breast will give infinite detail to that lump. And also other similar lumps that may be present in other parts of the breast, because that's part of my treatment that's going to be important for my next step, which is to treat, to manage the patient. But at the moment, I'm still diagnosing, and I want to know how many, is it a multicentric tumor? Is it a multifocal one? Is it solitary? Does it have a satellite nodule next to it? What does the rest of the breast look like? How has it caught the ductal system? Because these have implications on what I'm going to do with it next. And after imaging, I wouldn't fail in my duty to not mention PET scan, particularly the contiguous scan combination of a CT and a PET scan, because the next thing I want to know, sir and ladies, is that where all in the body has is gone. What stage are we talking about? Not just the TNM, even the clinical stage. What clinical stage are we? Because everything about that cancer further on is going to depend on the stage. And I need to, as a diagnostician, to find out what stage it is. So the best initially for lots of years, I was using simple chest X-ray to look at the target organ lungs. I was using an MDP technetium bone scan to look at the skeleton. And I was using the ultrasound of the abdomen to look at the liver, the three most important sites where this tends to go to as a prediction for. But now I'm increasingly, at least in the metropolitan cities, and even up to the regional cancer centers using the CT PET scan, because it's one complete survey of the whole body and will pick up even the minutest spot, because that spot, that one spot that I pick up, which my X-ray didn't pick up, is going to change ideally how I'm going to manage this patient. And as far as the imaging goes, that should be good enough, but that's not all. I don't know about the biology of this tumor. Am I dealing with an angry young man who's going to go on a rampage and destroy everything? Or am I dealing with a slow field fire, which is going to take days and ages to go out? Because I need to do precision oncology. I need to treat these patients according to what they need individually. I need to tailor their treatment according to the biological characteristics of that tumor. And in that process, now my researchers and my other people in the laboratories have not left me in the lurch. They've come out with beautiful molecular patterns, basal-like, tubal-like. They've come up with all kinds of next generation sequencing panels, which give me not only what mutations, what fusions, what amplifications are in this particular tumor, in this patient, they also give me what out of all the drugs that I have all across the world, everywhere, are there some which are going to particularly work on this mutation? Yes. So, till a few years back, it was just HER2 new. Now it's more than that. It's many mutations that I can act on. Targeted therapies, particularly for those mutations. So molecular diagnosis is now slowly entered the armamentarium. But is that available in the country? The answer, is no, it isn't. But it's getting better, and it will get there. And because science wants you to catch up, particularly science which is going to be translational and is going to be used on your patients.
Yes. So, Dr. Kaul, you're right. Medicine has progressed a lot, and even the treatment outcomes are improved because of the progress made there. Dr. Kalai Jelvi, in the real world for women, one of our speakers earlier said that they will only go to the doctor if they are unwell or if they feel sick. Now, sometimes that is just too late. So, breast cancer is a cancer which you can screen, like cervical cancer. You can have a pap smear every 2-3 years. Breast cancer can also have a screening, and mammograms have been used in the developed world. But in India, can this tool work? Mammogram as a screening tool work? Because one, there is a cost of institutional screening. Two, there is the availability. Plus, the entire mindset among women that, spending so much on this, at a time when you have COVID, you don't want to, take on risk. So what is going to work in our country, which is going to be an effective screening tool?
Yeah, I agree with you. But the thing is, see, the gold standard is only mammogram still. Whatever you do outside mammogram, it's going to be inferior to the results of mammogram. And we know there was a study done in Tamil Nadu by the Tamil Nadu Health System Project, where they found that around only 40% of the women are aware about mammogram. The 60% did not know in certain districts. That's a rough study, pilot study. And because there's a system, Tamil Nadu Health System Project is conducting on non-communicable diseases, where they do the screening for breast and cervical cancer, along with hypertension and sugar. But what happened was the 40% only knew about all these things. The 60% did not know what mammogram at all. So we have, even the National Health Mission, everywhere they're inviting people to have mammogram. And we don't have any screening program like what you do for children, immunization, where it's a compulsory immunization for all children. There's nothing like that in our country. So if you have a mammogram program for all women of eligible age, then probably that will be the only place where you can have mammogram screening for all women. And that's a long way. But however, from what I have seen in my career in the last, say, 30, 40 years, but things have changed when we didn't have mammogram at all. Now we have mammogram available even in primary health centers. The government of Tamil Nadu and as well National Health Mission is inviting people for screening mammogram. And it is only 200 rupees for, general screening. Mammogram is only 200 rupees. When compared to outside, it is 1,002, even up to the highest, it could be 8,000 rupees for the digital mammography or tomosynthesis. So now when it is available in the country and in our primary health centers and upgraded primary health centers and taluk headquarters, we have mammogram available. I think we should motivate and make the people aware that the mammogram is the simple and the only step solution to identify breast cancer early to prevent mortality. And we should prime all our people that mammogram should be done from the age of 40 itself. So I think the message is that you should tell all your people or send the message to the public that mammogram should be done, and it is very cheap in our country, and also should participate in screening programs.
All right. Dr. Kaul, it is very heartening to hear Dr. Kalai, Professor Mehrotra, I want to come to you. Now, it's very heartening to hear Dr. Kalai Jelvi talk about mammograms being available for just 200 rupees. But in the Western countries, mammograms will start as an annual screening only at 50 years or so. In our country, the median age of detection of breast cancer is 46 years. So if we start at 40, how many women do you think will be able to reach with mammogram? And is it a realistic thing that all women age 40 and above will be able to get regular mammograms in our country, given the infrastructure bottlenecks and the extent, the size of our population?
Thank you, Anisha. I think that's a very pertinent question that you have asked, and thank you for having me on the show. At the outset, let me tell you that India, although we say it's a country of India, we are United States of India, I would say. So there's a huge difference, huge diversity between facilities available, for example, in the most robust healthcare system, like where Dr. Karachari is coming from Tamil Nadu or from Kerala, and what you get here, even in the national capital region, or you get in Kashmir, or you get in Odisha, there's a huge difference. I would beg to differ from Dr. Kalaichari that mammograms are freely available. As in my opinion, they're actually few and far between. And as she had already mentioned, there's a problem with not only the availability of the mammography machine, the number of radiologists and radio technicians who are trained in interpreting a mammogram. And at the third issue is the cost. As she has mentioned, the private setups are usually between 1,500 to 2,500 rupees. Can be higher, can be lower. It have to be heavily subsidized to get it available for 200. And I'm so happy that certain setups in Tamil Nadu, probably in the urban areas, are getting it. As a matter of fact, I've actually been to many primary health centers in Tamil Nadu myself, and most PSCs and even CHCs do not have this facility. So as the government of India, which caters to roughly about 20 to 25% of the poorest of the poor of the country, and as part of the universal health coverage, that is the Ayushman Bharat, the recommendation is not to go for a mammogram for each and everybody.
Okay.
Recommendation is for the country as a whole. I'm not talking about individual cases. For example, if you have a family history of breast cancer in your immediate relatives, or you are some other reason genetically predisposed to breast cancer, obviously you should. As a matter of fact, we suggest even as young as 35 to 40, because Indian women have denser breasts, so they are not so easy to actually see through. But as you mentioned, roughly about there's a 10-year gap between the West and in India. So we recommend after the age of 40. But what happens if you have you develop, there are a lot of incidents of younger people getting breast cancer. Young girls up to even 25, 30, 35 years of age, especially some of these cancers occur in women who are lactating, who are little babies who are breastfeeding, and in those individuals in pregnancy or in lactation, those breast cancer also progresses very, very rapidly. So one cannot really miss out on we are a young country. I mean, the 65% of India's population is less than 35 years of age. So our recommendation is from the government at least, and that's part of the universal screening program that is part of the national program for screening on cancer, diabetes, and hypertension, is to start at the age of 30, not 40. And obviously mammography is not going to work at the age of 30, it is too early. So what we recommend is every 2 years, the lady goes for a basic examination with the primary healthcare worker or the doctor, who be a gynecologist or a surgeon, who does a clinical breast examination. Because this doesn't cost a lot of money, but it has, problem is you have to reach the person has to be okay with getting a breast examination. So there are privacy issues. You would not like a maid to do it. You would not like to do it in the open, which is understandable. But clinical breast examination done by trained hands actually is reasonably good, because see, in our country, as was mentioned earlier, 70 to 80% of the cancers are diagnosed late. So people here don't come with size 0. They come with, the earliest you would catch is stage 1 or 2. If you're unlucky, it is stage 3 and 4. So if you're trying to catch hold a tumor of size of a marble or a little bigger than that, clinical breast examination is the right way to go. For certain individuals who have a higher risk, who can afford it, definitely mammography is a better way of doing it. But for practical purposes, I feel self-examination is not meant to diagnose breast cancer, by the way. Self-examination is to get the lady familiar, as Sameer has mentioned. Let the lady be familiar and comfortable with her own normal breast. So if anything is abnormal, she approaches what is the recommendation for the general public is anybody after the age of 30, you go for a clinical breast examination. And then if needed, a fine needle aspiration with a simple syringe and needle, which doesn't again cost a lot of money. And in case you find something, go for a confirmatory mammogram. That is the way we are saying for this country. It is not ideal, but for a country of 1.3 plus billion people, one has to be practical also, and that is hopefully going to be a harbinger of things to come as and when mammography becomes more easily available. And talking about mammography, there are a good number of studies now which say in the West, especially from Canada or from the US and from Scandinavia, we say that mammograms are too sensitive. They catch hold of very early disease which may or
Never
never
progress.
actually become clinically relevant. So there is a group of people who actually are strongly against mammogram. So I personally feel that in India, we take the median path, do a clinical examination and mammography and FNA as required, depending on the individual. So in addition to precision oncology, what Sameer was talking about, that you tailor make the treatment for breast cancer. Similarly, you tailor make the investigation of choice for this country. I hope I have made
All
myself
right.
clear.
Right. So Dr. Mehrotra has raised very important points on what is going to practically work in our country. Things like overdiagnosis because for mammogram may be a bit too early in our country, but the lack of availability may, nudge us towards other methods that may work just as well. Now, we have a breast cancer survivor with us. Aisha is with us. So, Aisha, I wanted to understand from you what your experience was when it came to diagnosing breast cancer. Were you already aware that you should do a breast exam? Is that how you found out on your own, or was it you found out in a clinical presentation? How did you find out for yourself?
Yeah, good evening, everybody, and I thank you for joining me on this forum. And yes, I was a very active worker in the field of education. I was an educationist, doing a lot of work, but on and off, I was feeling a little of weak and sick. Then one fine day, it was a size of peanut which I could feel in my breast. In the year 2013, it was 2nd of October, when I could feel some very, very small lump, and immediately I visited the doctor. I think my case could have been at a 0 stage, as already spoken, but I'm sorry to say that after a biopsy being done, the results given were benign. So I was a little comfortable thinking it was a benign tumor. But going forward in a span of 3 months again, there was a regrowth in the size and it was very painful.
Right, Aisha, I just want to understand, after the biopsy, you were told that this is benign, right?
Yes.
And
but
then
it was malignant. It was malignant.
And you figured it out because it grew.
It regrew and it was painful.
Okay, then what did you do?
Obviously, then I went in for FNAC and mammogram, and there it was a question mark. Then again, a rebiopsy had to be done to remove that lump again. So lumpectomy was done. And again, when the previous slide was resent for the, was taken and resent for the results, then it showed that even the previous tube did contain the result as malignant. So then I started with my treatment, that is radiation and the chemotherapy, since 2013. That is how I started with my treatment. But initially it was I myself, because being from a zoology field, I'm a zoologist as well. Zoology is my field and endocrinology is my special subject. So I was aware about the basic biology, and that's how I could find the a small lump in my breast, and I became proactive about it.
Right. So Aisha, did you seek a second opinion the first time when you got your biopsy report saying that the tumor was benign?
That was my mistake. I did not go in for a second opinion.
Okay. But, till the time you got a second biopsy done, did you feel something was wrong? I mean, was it just the size of the cancer, the lump becoming larger? Was it something else that told you that, no, something is wrong?
No, it was the size and the pain. That's
Okay.
where I was, and I started going through the articles and various journals about the basics of breast cancer, the initial stages, and as being a zoology student, I knew about the point mutations and other thing. So I started studying more about it and started approaching the doctor and started taking my treatment.
Right. Aisha, stay with us, but I just want to understand from Dr. Kaul. Dr. Kaul, when she got her first biopsy result and it said that the tumor was benign, could a second opinion have helped her? Because this is a lab report, right? I mean, how do you contest a lab report? Take it for what it is, right?
Well, the answer to that question is maybe and maybe not, because if the tumor, sometimes what happens is that you strike, there is a lot of tumor heterogeneity, which means that the whole lump is composed of different, there is a solidified tumor, there is a liquefied, sometimes it can be necrotic in a certain area. So whether you get your biopsy absolutely right depends as much on whether you hit the right spot, which contained the tumor, as much as it depends on who's looking at it, which means it is possible that a more trained eye would be able, which is used to treating early, particularly this holds true in early cancers, well-differentiated cancers, where the eye which is trained to diagnose a particular cancer on that glass slide, looking at those cells, can be infinitely better. And there are people who do it more often, are much better, and their positive rate, true positive rate is higher. But it also depends whether the biopsy which was it taken from the right spot, because that's where half the mistakes are. Where if you are not sure of where you've taken it from a fat cell.
So, Dr. Kaul, what I wanted to find out
around the tumor.
Okay, aren't biopsies usually done by an ultrasound guidance and things like that? How, I mean,
not all the time. If there is a lump that you can palpate, which you can clearly palpate by your fingers, and if not see, I mean, unfortunately, because as you know, about 65% or even more cancers in our country, they come at stage 3 and stage 4, by which they've not only made a huge lump, they've also tried to start coming back to the skin and cause puckering and things like, and wounds on the skin. But if you're talking about early cancers, yes, if you cannot clearly palpate a lump, or its borders are rather indistinct and sort of merging with the surrounding thing, then of course it would be targeted by under an ultrasound or sometimes even under stereotactic, where they use soft tissue guidance as well to guide you. But so imaging can be used for lumps and smaller architectural distortions which are not clearly palpable to the human fingers. Otherwise, most of the routine lumps, T1, T2, T3 stage, you palpate them and you stick a needle in, because it happens in an OPD setting most of the time.
Right. Aisha, just a question. When you started your treatment, radiation and chemo, what stage was your breast cancer in there?
Yeah, the second biopsy, it was almost 6 months of difference, and it was stage 1.
Stage 1. All right. Naren, I want to come to you now. Dr. Mehrotra, Dr. Kalai, Dr. Kaul, they have raised very important issues. Technology is advanced a lot, and should you find breast cancer early, the survival rates are very high. But we also saw in the case of Aisha, a biopsy that didn't really play out as was supposed to be. So what do you think is the answer for more definitive diagnosis? Is it better technology? Is it better trained technicians? It's self-awareness. What do you think will help in better diagnosis of breast cancer?
Thanks. First of all, good evening, everyone. Thanks for inviting me, and it's my honor to be with you, with all our panelists, and that's an important topic that we are trying to tackle from the technology perspective, how we can improve efficiency or how we can improve healthcare systems inefficiencies via technological tools. Then, as we all know that there's a specific interest and increasing interest in the application of new artificial intelligence methods of machine learning to improve oncology care, giving the large numbers of patients diagnosed with cancer and significant amount of data generating during this cancer treatment. And all we are trying to make a deeper dive to breast cancer, which is the leading cause of cancer-related death among women in everywhere. And it is also difficult to diagnose. And the treatment success is increased really very early diagnosis. Let me share an analysis, a deep dive analysis, which is saying that after 10 years of annual mammograms, which is the standard of diagnosis, let's say, roughly 2 out of 3 patients who do not have cancer will be told they do and to be subjected to an invasive intervention and most likely a biopsy. So from patient perspective, you are thinking that you are positive, you diagnosed with a cancer, but and then it's increasing your anxiety level, but perhaps it is not true. And from another perspective, it's increasing the total cost. Perhaps you will take some treatments, unnecessary treatments from cost perspective. And coming to the diagnostic laboratories perspective, we know all that all diagnostic laboratories are in the midst of a transformation period in the face of decreasing revenues and increasing workloads. And there is a rise of demand to increase efficiency while maintaining and improving quality, and particularly in the clinical diagnostic that we are speaking of now. So, and on top of it, additionally, there is a shift toward precision medicines. Like Dr. Samal mentioned that mutations, more and mutation-specific therapies, targeted therapies are available now in different therapeutic areas and in breast cancer as well. So when we are considering all these facts, artificial intelligence has 2 prevailing points for cancer detection and diagnosis. Firstly, machine learning can detect patterns that might be opaque to humans. Secondly, machine learning offers a chance to reduce operator-to-operator error, what we are talking about. An algorithm, of course, certainly, this is not a replacement factor. I'm not saying that an artificial intelligence can replace a radiologist, but I'm only saying that looking to the developments across industry and across technological aspects, an algorithm can't serve, of course, as a sole arbiter for cancer diagnosis, but instead a tool that helps guide radiologists to more accurate conclusions.
Okay, Naren, we're going to try to understand how machine learning can improve our diagnostic, toolbox a little more in more depth during the course of this discussion. I want to come to Dr. Manjari Bhakre as well. Now, so far we've discussed, what are the diagnostic tools you can do: self-exam, clinical breast examination, mammography, biopsy. These are, diagnostic tests that can be done to try and find out breast cancer early. What is the difference between diagnostic and prognostic tests for breast cancer, and what role do these prognostic tests play in our country?
Sure. Yeah. Thanks, Aisha, for having me, and it's wonderful discussion that's ongoing. So what I would like to start with is there are really 2 to 3 different kinds of tests. I will just explain this with the example of a breast cancer. So mammography screening, or there are the multiple now versions of it, different heat map, etc. So these are screening tools. So at a mass level, you can run mammography, ultrasonography, etc., and understand whether the patient has any lumps when they come for a routine checkup. Then if there is suspicion, then they will go ahead and do biopsy or FNAC. So those are really diagnostic tests. And then one step beyond this is what is called prognostic test. So now the difference between diagnostic and prognostic is to diagnose whether a patient has cancer or not. And a prognostic test is once the patient is diagnosed with cancer, how aggressive is the disease? How will the disease progress? Is the disease biology very aggressive and the lady will have a recurrence of the cancer, or the disease biology is not so aggressive and the patient will do fine with the surgery plus radiation plus endocrine therapy in case of breast cancer for 5 to 7 years? She will do well on those treatments. So this is the course of treatment that a prognostic test decides. I will just, if you can allow me, I will just share one quick slide to showcase but I'm not. The disease biology is not so aggressive and the patient will do fine with the surgery plus radiation plus endocrine therapy in case of breast cancer for 5 to 7 years. She will do well on those treatments. So this is the Hello.
Yes, Manjri ma'am.
Okay. Yeah, so I'm not, unfortunately not allowed to share screen here, but
yeah,
what I was essentially saying is diagnostic test done to confirm the disease that lady has breast cancer or the person has breast cancer, and then prognostic test is done on the surgically removed tumor tissue to see how aggressive is the disease and then whether to take chemotherapy or not, or how to treat the patient with respect to any targeted drugs that are available beyond endocrine therapy. These kind of decisions can be done based on the prognostic testing. So that is essentially the difference.
Right. Dr. Manjari, I wanted to find out from you, in your practice, where you have, sampled so many of these tumors, how many of these are the aggressive ones? And, how many of these are the endocrine receptive ones? Because I guess then the treatment is different and the way the cancer reacts is also different.
Right. Yeah. And I forgot to answer the last part of your previous question, which is where do the prognostic tests happen in India? So prognostic tests actually are important in any country because they really tell the patient a personalized therapy which is tailored to that patient. In case of, especially in case of India, I think prognostic tests are very relevant. One, because the hormone receptor positive, HER2 negative early stage breast cancer patients for whom prognostic tests are available, they can be spared of chemotherapy. About 70% patients typically are at low risk of cancer recurrence and could be spared of chemotherapy, which avoids out-of-pocket expense if the patient doesn't have insurance. It saves money to the insurer if the patient is covered by insurance. Or for a big scheme like Ayushman Bharat, which is launched in India about 2 years ago, it will save really crores of money to Ayushman Bharat scheme if they can spare, if there is no need to give chemotherapy to the patients who are at low risk for cancer recurrence, and they will be operated to remove the tumor, given radiation therapy based on the tumor surgery, and endocrine therapy for 5 to 7 years. So that will really help patients save money, insurance save money, patients save a lot of side effects and
from chemotherapy
from chemotherapy and the treatments to it. And especially relevant point here, I would like to make one last point is, in a country like India where the patient to doctor ratio is really the 10 patients to each doctor or something like that. If the doctors can focus on the patients who are at high risk for recurrence, then they can follow them up but better. They can ask them for frequent follow-ups and also think of giving alternate therapies or something like that, different additional therapies to them. So from everybody's perspective, from the patient, from the insurer, from the doctor, and from the caregivers to the family, I think doing prognostication of the disease is really critical in India, I feel.
Right. So the question was, Dr. Manjari, that in your practice of all the samples you've seen, how many are the triple negative ones and how many are the endocrine receptor ones? Because the treatment is different, the progression is different. Can you help us there?
Yeah. So typically what we see in India, the percentage of triple negative breast cancer patients who lack hormone receptors and HER2 receptor is typically considered at about 25 to 30%. It ranges, some regions maybe little higher pockets compared to 20% in some other regions, maybe 30% in another, but overall it's about 25% in India. 75% are typically hormone receptor positive patients, and the percentage of HER2 new positive receptor patients will be about 25% on the whole. And yes, the therapies do change based on whether based on the hormone receptor status. If the patients have the tumor, breast cancer has hormone receptor positive disease, then they can be given endocrine therapy for 5 to 7 to 10 years, which is extremely protective. Whereas the triple negative patients really don't have any other options today besides chemotherapy and radiation therapy. However, there are more targeted drugs that are being introduced for triple negative. They're trying to introduce also. So yes, based on the hormone receptor typing and the HER2 typing, the treatments do vary. The prognostic tests today are only available for hormone receptor positive, HER2 negative patients. And in fact, Oncology is working on one for triple negative patients, which will be launched in about 1.5 years' time.
Right. Aisha, when you started getting treatment, did you go for these prognostic tests? Did you undergo targeted therapy?
Yes. Of course, prognosis test. I was about to ask Dr. Manjari about the same. Where in India could these tests be done, and what are they? Because as I know, US, they do conduct some prognosis tests, even telling the percentage ratio of what and how fast the cancer can spread. But I don't think in India I have, got the knowledge about this as of now. And secondly, yes, when I started with chemotherapy, the prognosis, as I said, I was unaware about it, but yes, target-based therapy, yes. After chemotherapy, because first I was on breast cancer. When I was detected with breast cancer, I went in for a routine chemotherapy. But later, probably after a year, I could feel some additional pain in my pelvic bone. And then when I went in for my PET scan in bone density, I could find that the disease had reoccurred in a bone. And then I started with target-based therapy, which was, of course, painless when compared to chemotherapy. And then it continued for a span of 1 year. And now I'm on immunotherapy treatment.
I see.
Right. Dr. Kalai Chalvi, I want to understand from you now, Dr. Manjari has also explained this prognostic testing to us, and Dr. Kaul had also spoken about, MRIs and PET scans, and, how they can help in understanding the extent of the spread of the disease, etc., if it is beyond the breast. Because, in India, we see many stage 3 and stage 4 cases. Now, how far do these techniques, imaging techniques of MRI and PET scan, help in treatment of cancers and breast cancer particularly? And how accessible are these to everyone? Because MRIs and PET scans are expensive.
Yeah, I agree with you. But when it comes to treatment, the treatment is done in tertiary centers mostly. And when you prescribe chemotherapy, this can be carried out at district headquarters and other smaller hospitals where daycare chemotherapy is available as of now for the last 2 to 3 years. I think in a specialized center, or when you go to a city or second tier cities, these investigations are available. And MRI, of course, it needs dedicated breast coil, and the interpretation should be very good. And PET CT scan is in major cities now, and even 2-tier cities it is available. PET CT scan at the cost of 10,000 rupees. And some centers are doing it free also. I think in Mumbai also they're having free PET CT scans. And so many people now, I find, even from rural areas, when they come for treatment, automatically the CM, our Chief Minister Health Insurance Schemes, gives a free PET scan. If you have the insurance scheme, you have a free PET scan. The insurance scheme to have all investigations free, including your mammogram. So when you have an insurance scheme, you can automatically have a mammogram even as a screening test. So PET CT scan is available now. It is quite reachable. What was 10 years ago, now it is quite reachable, PET CT scan, and with the insurance scheme, you can get it free. So I think
right.
investigation, when it comes to PET, I would do it on any patient with breast cancer to assess the, stage of the disease in the, first line itself. Once you confirm the biopsy, then I would do a PET-CT scan if it is available. I think now in a tertiary center, we have PET-CT scan for almost all patients wherever it's necessary. We don't think, there's no second thoughts about doing a PET. If it is necessary, we will do it. The routine MRI only for special cases where, you do a breast conservation surgery. That time an MRI is very essential. So an MRI, when it is available in a tertiary center, it can be done.
Uh, Professor Mehrotra, after listening to Dr. Kalaichalia, I really wish I was in Tamil Nadu. Insurance covers a mammography. I paid through my nose for it. It covers a PET scan. Facilities in South India and West India are really very good. But some of the issues that Dr. Manjari has raised about, prognostic treatment, and, that could help you save on a lot of cost, even insurance costs and Ayushman Bharat. Do you think that these are workable solutions? Can MRI imaging and PET scans also become, available more freely to be, for better treatment, for understanding the extent of the progression of the disease all through India?
Anisha, as we speak, it's a work in progress. I remember the time when PET scans had just been recently introduced in the country. They were available maybe in 3 or 4 metros. And now, as mentioned by Dr. Kalaichari, they are generally found in tier 2 and 3 cities as well. But it's all a question of supply and demand. As the demand increases, the cost of the machine is going down as we speak. However, technology is expensive. So if you want first world treatment and first world investigations, you have to pay for it. There are various insurance schemes, both from the private setup and the government setup. They are still to percolate to each and everybody in the country. As you mentioned, if you got a mammogram or you got a PET scan, if required, you have to pay through the nose. That unfortunately is true for most of the country. I would say 80% and more of the population have to pay themselves, which at times, as you possibly know, cancer and disease overall, but cancer specifically, is the single most largest cause of people catastrophic expenses, where people have not only to finish their life saving, but also have to sell their land or houses. I mean, I'm not trying to be a doomsday person, but we do see it on a regular basis. As I mentioned, we are the United States of India. So we have very small percentage who are ultra rich. They can fly out to any part of the country or the world to get the best treatment. And that's a huge number, probably more millionaires than you can possibly imagine in this country. But for the vast majority who are in the middle, and for a even bigger number who are at the bottom of the pyramid, the universal health scheme has just started, and it has been going on. Some states are doing far better. For example, a couple of states in the south, not all, but a couple of states in the south are definitely doing better than others. But gradually the country is picking up. So I won't say it's all doom and gloom. In spite and despite of what we talk about, how bad the public health services are, and at this COVID times, we are unfortunately coming to know the reality of the situation. But still, if you are in the major cities connected, you can get your work done. It is not impossible.
Dr. Mehrotra, what I wanted to know was that, how can prognostics tests be fit into our public healthcare system? What Dr. Manjari was talking about, what Naren is talking about, how machine learning or algorithms can also help statistically improve diagnosis. How much room is there in our public health system to adopt these? Because who knows, they may help you save crores of rupees.
Oh, absolutely. I think that's the way of the future, and it's a work in progress. What our learned experts are talking here, talking about artificial intelligence or doing specific prognostic tests, they are available. Unfortunately, they are expensive. Some of the insurance companies are covering it at the moment, But I think in the next few years, things are going to get more widely accepted. I see things like liquid biopsy, you might have heard about, in which they take a sample of your blood and they see that if there are remnant cancer cells around. That's becoming more popular, becoming cheaper and more accurate. Similarly, various diagnostic tests, and I think OncoStem is doing some of the thing about CAN assist. Then there are various innovative companies in our country which are looking at thermography. They are looking at breast light, the variety of diagnostic aids which are being tested as we speak. However, for them to become mainline and to become part of the public health system, I think we have to wait for a while for adequate amount of studies to be there, to be published in peer-reviewed journals, and to be accepted. I think that is the way of the future, no argument on that. And I compliment colleagues for talking about it. But maybe another couple of years or 3 years time, when we have a similar session, we'll have more good news to share. And we will, we in the public health system are definitely looking forward to something that is innovative, that is accurate, and that will bring the cost down, because that really is the major stumbling block. In addition to awareness, we have talked about such a lot. The other thing is, if I know there's an investigation I can't afford it, what do you do about it?
Yes, the cost of treatment is also an important parameter here. Right, and a lot of people are pushed into catastrophic poverty because of the cost of healthcare in our country. Dr. Kaul, you wanted to add a point here about these prognostic diagnostics and what Nareen was talking about.
Just a couple of thoughts about what people have been already talking about.
Yes.
And as I sort of second the view that even in the United States of America or in the West, the cancer treatment is the single most cause of reason for personal bankruptcy. And it's tabulated and estimated, not to speak in our part of the world, because we are the low middle income country. Now, just to give you some objective analysis of what does our army look like, we already know what we are confronted with as far as the incidence of cancer are part of the country and the estimated incidences are concerned. But what objectively, let me leave all you ladies and my friend Ravi with some figures. Because according to me, I again reiterate that not are we deficient in as far as the awareness of basic awareness in the community of cancer and its sort of things and details are concerned, but also we are heavily inadequate in the technical and human infrastructure required, not only in the quantum of that, but also its distribution. So there is inaccessibility of care. So at all levels, we are deficient and we need to work. I'm quite happy to take on board what Ravi feels that it's a work in progress, yet it is. But still, let me tell you that we should have this 2020 year, as per our own statistics, we have had about 450 to 500 comprehensive cancer centers in the country. And what do we have? We have 200 to 250, which is 0.2 per million in India versus about 4.4 per million in the United States, and 40% of which is in these 8 metropolitan cities. You see, and if you want to look at the oncology ratio, there is one oncologist per 1,600 new cancer patients in my country. Whereas what I ideally need is one oncologist per 100 patients, for instance, in the United States. Now, there are only 2,700 mammograms installed in India, sir, and which represents less than 5% of that an equal number in the United States. And do you know what my mammogram ratio, average yearly mammogram ratio is? It is less than 1%. So it's not only about availability of the mammogram, it's about the willingness of my women to be comfortable with their bodies and subject themselves to a mammogram. You see, it's easy when to provide something. And do you know how many the total PET scanners in India? Still about 120. And they are all in the metropolitan cities. Advanced imaging technologies, only 30% of my cancer centers across this country have really advanced CT PET scans in all these countries. Next one. And just to give you an idea, we are far deficient in that. And if human infrastructure, I should have had 750, I should have had about 2,800 to 3,000 medical oncologists in 2020. I have about 750. I should have had about 1,900 to 2,000. These are figures given to me by the government. So even in 2020, there is a shortfall of figures in everything. In the dedicated cancer beds, in the LINACs, there are only 350 LINACs in the country. In 2020, I should have had something like 7,500 to 9,000, and 900. And 2,000 are required, actually, ideally. So we are deficient in every stage, but more important, reiterating the fact that yes, machine learning, artificial intelligence is already proven. The Google study, the seminal study, which said that when they looked at X-ray chests, and they were to 11.9% better than the best minds, even reading X-ray chests. So I'm sure the answer lies there, but that is not. We are not only deficient in one segment, we are deficient in all segments.
No, that we understand, Dr. Kaul. It's not just oncologists, doctors, it's policemen, it's every stage, because of the sheer size of our population, that to match up to the availability of Western countries, it's not going to happen overnight. It will take time. In the interim, we are looking at means to bridge this gap in a faster fashion and perhaps in a cost-effective fashion. So I'll come back to Nareen. Nareen, please tell us how, in simple ways, how machine learning works. Like Dr. Kaul told us, you don't have the machines, you don't have trained technicians. How are you going to have improved outcomes? But can there be a bridge? Can there be something from technology that can help us? Now, in COVID, we've seen doctors doing teleconsultation. It works for many people. It works for many patients who are having chronic conditions. So can we have technology as a gap, as a bridge?
Yeah, that's the crucial part, actually. Discussions are really exciting. Actually, already Professor Samer shared an example from Google Health. So, and then as Professor Ravi mentioned, that is moving target, and in an improving, let's say, progress. But of course, how we can position these technological wonders in favor of the, more importantly, for the overall target, which is the case for the right patient, for the right treatment at the right time, knowing the fact that there is a deficit. And actually deficits coming from the, perspective, first of all, from the shortage of the trained healthcare providers. Not only machines, but I think that on top of the machines deficit, we do have it everywhere. Of course, it's changing from one country to another one, and considering that in the low middle income countries, we are facing these types of problems more and more. However, the shortage of the trained healthcare providers is a common factor, and then we can bridge this via artificial intelligence in favor of making artificial intelligence mitigating the impact of the severe deficit, like replacing in the early phase for the early diagnosis, and after having the suspicions or having a strong understanding of having a positiveness, then making them refer to the right center. So minimizing the workload, replacing this period, replacing this period, let's say, via artificial intelligence in order to limit access to life-saving cares in developing nations around the world. So that's one piece. This is mainly from the trained healthcare providers' perspective. Coming to the cost, definitely. It's going, artificial intelligence expected to decrease the cost of the screening test. Why? Because there's gonna be more shortened time, minimizing resources needed for the screening tests, minimizing the manpower, increasing the efficiency and accuracy mainly. And then it's going to increase the affordability. And then knowing the fact that affordability is a big problem in low middle income countries like in India, mutation testing or having a basic testing as well can be a problem. So it's going to minimize the cost of the testing. But from governmental bodies' perspective, the total cost of the screening can be decreased. For example, we know that another study, which is conducted by Google Health with 2 cancer hospitals in UK and 1 in US, showing that how artificial intelligence can improve the efficiency for the false positiveness and the negative positiveness. And having said that, we know that artificial intelligence total diagnostic cost can be reflected directly into total minimization of the resources while increasing efficiency. So that's gonna be minimizing the burden of the governmental bodies, healthcare systems. So in a nutshell, first of all, coming to the fact that there are deficiencies, and then how we can tackle these deficits by artificial intelligence. Manpower, or then having the first early diagnosis piece by artificial intelligence, minimizing the cost in order to increase availability and affordability for screening tests, and minimizing the burden for the total healthcare systems. So I see that how we can position.
Yeah, artificial intelligence can help us to told us whether it is trained technicians, whether it is cost and efficiencies, three places where this really helps. Now, Aisha is a living example of people fighting breast cancer in our country. And Aisha, I'm sure after hearing all that you've heard today, you have a lot of questions about the newer technologies that can, reduce the treatment time, uh, make you feel better. And I think you have a lot of questions about what Dr. Manjari is working in, the prognostic testing. So if you have any questions to Dr. Manjari, please go ahead. And for the benefit of everybody here, we'll also understand, and everybody watching, what are these prognostic tests? Have they been developed in India? How accessible are they? Please go ahead, Aisha.
Yeah, I was chatting with Dr. Manjari. Thanks, Dr. Manjari. See, I was, as I said, I'm always going through the articles and the abstracts from various journals and other things. And I had, of course, come across the Mama Print, which US conducts to know the percentage, how fast the tumor could grow. And I mean, the percentage rate of tumor cells in the patients. But now Dr. Manjari, she just gave me the information about Can Assist Breast, which is going to conduct the similar type of test in India. I said it's a boon for survivors.
So, Dr. Manjari, can you tell us what this test is about? What is the Can Assist breast testing, and who is this for?
Yeah, I will. Can you see my slide here? I would like to just showcase one slide. Can you see the slide?
I cannot see it yet, ma'am.
No, it's not visible.
No.
See, PET scan and the bone density, which I got it done, these can be done once we get to know that the disease is growing. But I think the Mama Print, which I said in US it is conducted, I mean, it is done on the patients, that tells us about the percentage rate. Yeah.
Dr. Manjari, we can now see your screen.
Yeah.
Perfect. Yeah. So thanks, Aisha, for asking this question. So what prognostic tests do the whole is assess the tumor biology in detail to see how aggressive is the disease, whether the patient is likely to have the cancer recurrence in it at another site, maybe bone, liver, brain, in the next 5 to 7 to 10 years. So that's what prognostic tests do. And what you refer to, Mama Print, Oncotype, there is the tumor Prosigna and Endopredict. These are all available in the West, and they have been used quite extensively. They are also in various international US and European guidelines for treating breast cancer patients. Early stage, hormone receptor positive, HER2 receptor negative breast cancer treatment plan. Now, they are not included in ICMR's guidelines mainly because these have not been validated on Indian patients. And why that is relevant is because Indian patients, as we all discussed, the median age is earlier, the premenopausal disease, tumor burden is higher. Mostly women come with one node positive disease, T2 tumors, grade 3 tumors. So inherently, there are certain higher clinical risk factors as well. And so what is important is what ICMR has written is because these are not well validated on Indian patients. So with that thought, we started developing Can Assist Breast about 9 years ago. and it is entirely developed in India. Prime 95% patients are Indian patients. We have developed this over last 6 years. We showed all the analytical clinical validation, got all the accreditations, ISO certification, CE mark. It is run in our NABL and CAP accredited laboratory in Bangalore. And what can that is, it is only available for hormone receptor positive, HER2 negative, early stage, that is stage 1, stage 2 patients. We get the tissue, the surgically resected tumor tissue from the patient, along with the ERPR report and the histopathology report. We perform immunohistochemistry for 5 biomarkers, which are really indicative of the tumor biology. And these 5 biomarkers are not ERPR, HER2 or P67. These are really 5 markers involved in why the tumor cell leaves the tumor in the breast duct and travels along the blood vessels, lodges itself in the liver, and how does it form another tumor in the liver. So these are the steps that the cancer cells go through is what is captured in our 5 biomarkers that we do by immunohistochemistry on an automated Ventana platform. And then that information graded by oncopathologist goes into our artificial intelligence-based algorithm, and along with the tumor size, grade, and node status, and we get a risk score. This risk score is a number between 0 and 100. If the risk score of the patient is 15.5 or low, she is called as low risk for cancer recurrence, and she has already had surgery. She can, of course, get radiation based on the kind of surgery and the disease remaining, etc. But she can avoid chemotherapy and straight away go to endocrine therapy for 5 years to 7 years. That is up to the patient and the doctor. Whereas if the patient is stratified as, if the risk score of the patient's tumor is beyond 15.5, then we call her at high risk for cancer recurrence. The likelihood that the patient will get the cancer come back in the next 5 years is high, and hence she benefits from adding chemotherapy to the treatment regime. So that is essentially what Canasys breast is. It is entirely performed in our lab in Bangalore. We give the report back in 7 to 10 days, and the cost is 1/5 of what you would hear from Mama Print and Oncotype, etc.
Right. Dr. Manjri, just one question. So here
Sure.
I would have to come and give a fresh sample, right? So the biopsy has to be done again.
No. That's a very good, important question you asked. I'm glad you asked. We never ask for any repeat biopsy or anything. That is surgically removed tumor sample is what we ask for to be shared with us. The patient does not have to go through any more poking, not even any blood sample, etc.
But where do you get the sample then?
The tumor tissue that is removed during surgery is typically preserved as formalin-fixed paraffin embedded tumor tissue. It is stored at room temperature.
Okay.
It is with the hospital where the patient was operated in the pathology lab. So the patient can issue the sample and then send it to us just at room temperature shipping. Our people will of course help manage the entire process.
Dr. Manjri, I had one question. Is it similar to the block test or it is different?
It is
same.
It is performed on the tumor, not
yeah, it is performed
on that tumor tissue itself.
Dr. Clyde Shelby, yes, we understood, Dr. Manjri, that this is the tumor which was removed during the surgery, which is used to then assess the risk score. Dr. Clyde Shelby, are you using such methods to then, tailor-make the treatment for breast cancer patients?
Yeah, see, we are not using on a routine basis because the percentage of patients who come for this testing is very, very low. See, when you see a patient, they already have a node positive tumor or stage 1 with node positive or stage 2 with node positive who do not qualify for this high-end testing. So there are people who can afford, but this is not available, say, these kind of tests are not available under the insurance scheme of the government. But we have the ERPR and HER2 positive testing, which is done in the insurance scheme. So it is free for them. So this test, what you say, the adjuvant online or Oncotype DX or Canasys, anything if you want, you ask the patient to pay for it. So especially the middle class people who can afford, or the upper middle class who wants to get it done to know whether they need chemotherapy or not, those kind of people are there who are willing to spend. On a routine, people get this NGS or even Foundation 1 testing done for 1.5, 2.5 lakhs. Just like that. There are people who do it. So who wants it can do it. But otherwise, we have to use all the prognostic markers, whatever we have, and decide on chemotherapy. I think most of our people whom we see require chemotherapy. The percentage of people who need this kind of test and decide on chemotherapy or avoid chemotherapy is very small, even 0.001%.
And Dr. Kaul, is this because most people present themselves with breast cancer at a later stage? So, I mean, it's just too late for all the prognostic tests?
No, it has to do with the subset in which this works. It's a predicting fact. It's a predictor as well, in the sense that a subset of pre-menopausal or post-menopausal women who are node negative and are estrogen and progesterone receptor positive and HER2/neu negative, we would like to avoid any additional therapy, which would be, for instance, chemotherapy particularly, because it has profound and it has considerable side effects. So therefore, to avoid that, the practical utility of a test which will predict whether we add any benefit to these patients by giving chemotherapy or not. And that the benefit could be to the tune of anything between 8 to 19% in various series across the globe. Now, that's a significant amount. So which means if you give it in a block fashion, you would be giving chemotherapy with it and imposing those many patients to the side effects, which will at the cost of no benefit to them at all, clinical benefit to them at all. So how you do it, there are 2 or 3 tests which are standard validated. I'm a friend of Oncotype DX is validated. And I'm happy that in my country, based on my Indian patients pool, that CanAssist is available and is also affordable to my population. So I have, let me admit it, I use it across the board, but in this particular subset of patients whose numbers may be small, but yet in a busy breast practice, they do come up and they are fairly significant. I would have said that every month I would tend to use this test at least on 2 to 3 women. At least on 2 to 3 women, and that's my small practice, and you can imagine that across India. So it's a valuable contribution. It's a scorecard which tells you the relative risk of this patient developing a recurrence in the next 10 years, so that you can tailor your therapy and I can save people from unnecessary treatment, because that's what science is about. That's what research is about. I'm really, really happy with OncoStem that they have done this right here in my country. Atmanirbhar Bharat. That's what we are all working for.
Yes. So Dr. Kaul, we hope that we will have more technological innovations itself and be able to provide the right care to people who are battling breast cancer. Dr. Mehrotra, what could be, in your mind, where do you see breast cancer diagnostics in our country from here on? You have said that clinical breast examination should be the first port of call for us. So once you have diagnosed it and you've done a biopsy and we've overcome the shortages of manpower, etc. For treatments, in the public healthcare system, in Ayushman Bharat, what kind of technological innovations are you looking forward to in the next 5 to 10 years? Dr. Mehrotra, I request you to please unmute yourself.
Sorry. As has been the theme for the evening, it is basically hope. It is basically looking at Atmanirbhar, as Samir says it very eloquently, and mirroring our Prime Minister. At the end of the day, our problems are unique. As we mentioned, roughly 5 to 10 years earlier than the West, a greater number, nearly about 1.5 or 2 times the triple negative, will not respond to treatment. So we have to find our problems in the lower middle income countries. I'm not talking about I would compare myself to my country to country which is similarly placed. For example, the BRICS. So you got Brazil, China, South Africa, and Russia. These are the countries which we are going to be comparing with the hope that one day, hopefully in the near foreseeable future, we'll be able to compete with any in the world. I am still a great believer and an optimist in the Indian Jugaad, in the sense taking the best of minds, not only overseas, but also in India. And there are many, many innovative companies which are working not only in Bangalore or in Hyderabad, but in nearly every part of the country, which are looking at innovative technology. How we can take the investigation and the treatment to the patient's doorsteps. For example, there is a movement in Odisha and in Madhya Pradesh where they are using the district hospitals, training the the primary caregivers there, paramedical and medical, for giving chemotherapy. After it has been approved by a major medical center or a tertiary care medical center, the patient can go home rather than clogging the system on living with relatives on the roadside. He or she can go home and or at least go to some relative who lives in a relatively smaller city but not a metro and get the same treatment he or she can in Bombay or in Delhi or in Hyderabad, for example. So rather than moving the patient, if we can move the medical care system to the patient, that obviously, I'm sure all of you will agree, is the better way of doing it.
All right. So decentralization is a theme that we hope will make diagnosis and treatment of patients easier for a large number of people in our country. Now, we're coming to the close of this session, so I'm going to take closing comments, a few takeaways from all of you, and I'd request you to keep it a little short since we have a little time. Dr. Kalai, what do you think in our country will work best? Now, in your setup, mammograms are working very good. As a diagnostic, is awareness about self and then reaching out to the doctor going to work? Is screening and your mammogram going to work? What do you think is going to work best?
Yeah, I think we should focus on screening, because going for all the other higher levels is not going to really work. Increase the awareness and make screening as a mandatory one, or you at least make it reachable to all public. At least you in each state should make it available for their own citizens, so that no woman comes with an advanced stage. In that case, you will avoid deaths due to breast cancer, which actually is the largest number of cases who die are from breast cancer and cervical cancer in our country, which both are preventable. So I think the government's National Health Mission, as well as the other state governments, should make it a point and make mammogram as a mandatory test available for women in their 40s.
All right. Dr. Paul, very quickly, what's going to work best to diagnose early stage breast cancer in our country?
I think not just one thing. I start with awareness. I will end with awareness again, but in between, I will put things like taking the screening, but making it screening to drive value into the system, make it screening for breast cancer, for cervical cancer, for oral cancer and colonic cancer. And if you can club it into one screening program, you will get more economical results and better. Number three, take the National Cancer Registry program very seriously, because our recordings are bad. We need to monitor them, derive analysis, and then have all the machine learning and artificial intelligence and analysis and bioinformatics drive value into our system. And of course, provide at every level what is deficient, increased access uniformly to our patient populations across this heterogeneous country, uniformly cancer care services of an optimum degree. And again, I'll end it again with awareness. So awareness at every.
Right. Awareness, of course, is very important. Aisha, your last word, having been through all the treatments, you're aware and you do research also. So what's your message to all those who are watching who may have or may not have breast cancer? As a patient, what more can you do for yourself?
See, first thing I say is courage. People say sky is the limit. I say mind is the limit. If you think cancer is a dreaded disease, that means you are surrendering yourself to cancer. I think we are more powerful than cancer. If we are strong, we can conquer cancer. Cancer cannot conquer us. So to all the cancer patients, I say, when you hear this word cancer, remember it's just a word. It cannot harm us. It cannot demotivate us. It cannot de-strengthen us. So please, I request the cancer patients and the survivors, absolutely do not think that it is going to eat you. You are more strong. Stand strong. Your sky is not the limit. Your mind is the limit. Think that you can and you will stand against it. See, me, I overcame breast cancer by Lord's grace, the bone cancer, even my liver is slightly affected. But I say, whatever it is, I'm stronger than this particular disease. So please, I request the survivors and the cancer patients not to panic.
Right.
It's just
Please
a word.
that is a message that Aisha has. Naren, very quickly, what is in your mind the best way to diagnose breast cancer early in our country?
Big responsibility for us to improve healthcare systems in India, and the full dedication from our part to work more and more how we can increase awareness. I see that as Dr. Samir mentioned, awareness, because we are working on the improving therapies and now curing therapies for breast cancer. If we can detect earlier and earlier, then we can give more chance to be cured to patients. That should be the target objective, our objective.
Dr. Mehrotra, your best tool for early detection of breast cancer?
Well, it is something very close to my heart. And to sum it up very briefly, being a preventive oncologist, in addition to awareness, I would say the best thing would be looking at frugal innovation, making sure that our youngsters, our scientists, our physicians can come up with ideas which are specific to India, we can make sure that we move the patients, rather the care should be moved as decentralization, so they can be treated where they are, given world-class or at least national class treatment, making sure the investigations become affordable. And also, one thing which we haven't talked about, maybe at some later stage, is looking at survivorship, which Aisha has so bravely put up. So living with cancer and living after cancer, pain-free, making sure that just in case it recurs, it is caught as early as possible using relatively non-invasive or minimally invasive technology. That should be the way to go. And also lastly is capacity building, making sure that our primary care doctors, even our MBBS students, they are not really taught about breast cancer or cancer overall, but especially breast cancer is actually a neglected subject for our medical students at the same time. So I feel a push for medical education, a push for innovation, and a push for decentralization are three things are very high on my wish list.
Right. Before I come to Dr. Manjari, I'd like to tell all those who are watching, in case you are interested on the CanAssist breast test, do go on to the website oncostemdiagnostic.com for more information. And Dr. Manjari, your last words. You do a lot of prognostic testing, but for our country, what's going to work best to detect breast cancer early?
Our country, what's going to work best to detect early is awareness amongst women, and go to the doctor. Do not feel shy. Do not feel intimidated. It is no more a stigma. It's no more a taboo. And there are excellent treatments available. You really must go as early as you can, because don't be in a denial, and get it checked right away as soon as you feel a lump or you suspect there is a cancer. Please visit the doctor as soon as possible. That is the best. Early detection is really excellent and great prospect for the country. That would be my one message to patients.
Right. I would like to thank all our panelists for joining us today and sharing with us their expertise and their views on how to detect breast cancer early, what are the best diagnostic tools which can work in our country. There's a couple of websites that you can visit for more information. One, of course, is oncostemdiagnostics.com. You can also find out more about breast cancer www.cancerindia.org.in for more information. And of course, do show us commitment towards creating greater awareness by signing the pledge to fight breast cancer and make India free of breast cancer. There is a link in the comment box of this show. Do click there, or you can even visit the IHW Council page, sign that pledge, share it with your friends on your social media handles, tag 5 people and create awareness so that we can fight this disease and win. Like we see so many of our the survivors of breast cancer who joined us on the show, they all win and we all will win. Should we be together on this and create awareness about breast cancer and how to fight it. A big thank you to all our esteemed panelists for joining us today.
So much for having us.
Yeah, thank you.
Thanks a lot.
Thank you. Goodbye.
Very well conducted. I must congratulate all of you.
Thank you so much, sir.
Bye-bye. Take care.